Next, what are your recommendations for feeding infants with large losses from intestinal stoma? Which is the best milk formula to feed these children, and how best would you increase the volume of enteral load?
So the answer to that question would be that it depends on the cause for the losses from intestinal stoma. For example, if there was a bacterial infection that could be treated, I would of course do that to decrease the intestinal losses. If there was significant malabsorption because much of the bowel was removed, I would take one approach. Or if there was inflammation, I might take a different approach. So the recommendations for feeding infants with large losses really depend on the cause or etiology of the losses. My bottom line would be that my choice of formula would be linked to the pathology in the infant, and my choice of formula would be that formula which allowed me the best rates of absorption of the nutrients that I could accomplish. So I guess I'm hedging in my answer to say my recommendation would depend on the cause, and I would use a formula that would correspond directly to the pathology in question. So similarly, to answer the question about what is the best formula to feed these children and how best is it to increase the volume of enteral load, my answer would be, again, that I would use a formula that would probably be very simple. When I say simple, I mean simple in terms of the choice in form of carbohydrate, simple in terms of the choice in form of fat, and simple in terms of the choice in form of amino acid. In terms of increasing the volume, I would start with a very small volume, and I would increase depending on the tolerance of the individual infant or child, so that I would increase by perhaps 3 to 5 mils per day, perhaps if it was a small child, or slightly faster in a normal child, but my rate of increase would totally depend on the tolerance in the child that I'm dealing with.
Okay, thank you very much. Next one, do you have suggestions as regards feeding infants with congenital heart disease and suffering from heart failure to improve their weight prior to cardiac surgery?
So again, a good question, very challenging for the nutritionist. Often infants with congenital heart disease, especially those with heart failure, are intolerant of volume of feeds, so that if a normal infant can take, for example, 100 milliliters per kilogram per day, an infant with congenital heart disease, especially with heart failure for various reasons, can often not tolerate that volume. So one of the ways that we try and improve the weight gain prior to cardiac surgery would be by concentrating the feeds. So if a normal feed normally would have, for example, 20 calories per ounce of feed, by concentrating the feed, you can go up to 24 calories, 26 calories, or even 1 calorie per meal, or 30 calories per ounce. So it is very challenging, and other than concentrating the volume or concentrating the feeds to increase in the nutrient density, there's really not too much else that one can do. I would maximize the drugs to control the heart failure. That in itself may improve the infant's ability to tolerate larger volumes of formula or feeding, but it's very challenging.
Number 3, what is the best strategy for managing pediatric oncology nutrition where there is ongoing chemotherapy coupled with sepsis and side effects of the drugs?
So that's actually a really tough question for a nutritionist, since if a child has cancer, if they're undergoing chemotherapy, the likelihood would be that there would be complications of the chemotherapy, and two of the typical complications would be nausea and vomiting, and also it can cause some damage to the mucosa of the mouth, possibly the throat, so that it would be hard for the child to tolerate feeds by mouth. If the child also had sepsis, if they had a fever, if they were quite sick, if they had other side effects of the drugs, it would be extremely challenging to manage the nutrition of the child. So I guess I would say that my general rule would be to use the oral route of feeding if that were possible, so that if one could control the nausea by using appropriate medications, and if there was not too much mucosal pathology, I would try to feed the child by mouth with fairly bland foods and foods with high nutritional value, but foods that the child would be willing to accept. My second choice would possibly be nasogastric feeding, but once again, if the child were nauseated, or if the child had significant mucosal damage from the chemotherapy, that might be difficult. So my third choice would be intravenous feeding for a child who is unable to take feeds by mouth because of nausea or mucosal damage, where there's side effects. So again, the strategy would be based on the degree of complications or side effects and the degree of nausea associated with the chemotherapy. I would start with simple interventions, only go to the more complex interventions as is dictated by the clinical status of the child.
Very challenging indeed. Yeah.
Yes.
Next question. Is it advisable to use formula for premature babies with intrauterine growth restriction in order to achieve better weight gain for these babies?
So our first recommendation for all babies is breastfeeding, including infants who are born with low birth weight or intrauterine growth restriction. So we would recommend breastfeeding for that population. If for whatever reason the mother can't breastfeed the infant, then we would definitely recommend the use of infant formulas, not only for infants with intrauterine growth restriction, but for all infants. So our first choice would be breastfeeding. Our second choice would be the use of formula. If a mother breastfeeds initially for the first month or two and then wishes to give up breastfeeding, once again, we would recommend formula for this group.
Okay, thank you. How would you build a proper calorific intake in an extremely low birth rate who is very sick in the neonatal intensive care unit?
So once again, a very challenging problem for dietitians and nutritionists in the neonatal intensive care unit, because if the infant is extremely below birth weight and on top of that is very sick, their ability to tolerate nutrients would be limited. So I guess my approach would be, one, that I would not aggressively feed an infant until they were metabolically stable, meaning their glucose was stable, their calcium was stable, and they were metabolically stable, and that if they had sepsis, the sepsis were adequately treated. If the infant were metabolically stable and they were extremely low birth weight, we would feed the infant intravenously, because the infant obviously would not be old enough to tolerate oral or enteral nutrients. So we would start very slowly with a slow volume of intravenous feeding. Depending on the tolerance of the infant, we would slowly work up from low volume to intermediate volume over a period of 3 to 5 days. And then probably after a week, we would try to get the baby up to total volume and total nutrient needs, again, intravenously. We would monitor the baby on a regular basis, primarily monitoring electrolytes, glucose, other minerals and vitamins, and to ensure that the baby was metabolically stable. And again, depending on the tolerance of the baby, we would increase their energy intake to aim for approximately 120 kilocalories per kilogram per day, and other levels of nutrients that would be appropriate for the extremely low birth weight infant. But again, very challenging in the NICU for the nutritionist and dietitian.